Dr. Amit Janu is a associate professor in Tata Memorial Hospital. He is a very well experienced and very well read radiologist, and he's one of the few radiologists who has very good acumen in CNS radiology. So let's hear it from Dr. Amit Janu. Amit, over to you.
Thank you so much, Vijay, for the nice introduction. And without wasting time, I will go on to the presentation. So basically, when we are talking about metastasis plays a significant role because it will upstage the disease significantly. So just to give out the incidence of brain metastasis in patients with lung cancer, it is around 20%, and it is a part of guidelines while doing you want to do SPRT or WBRT. So there is a specific protocol to be followed when we try to stage the brain, is that we have some specific sequences like T1, T2, flare, diffusion, GRE, and the post-cancer sequences, which have its own significance. It will try to help you in distinguishing from primary brain lesions from primary benign conditions, and sometimes the chronically recurring conditions like chronic ischemic changes. So if you see this lesion, this is a solid lesion here, very well marginated. The area that you see in the right here, it is the edema, and then you will see that it is having an enhancement. So this is a classical presentation of metastasis. It is not showing any other features like hemorrhage or something that is there in this particular patients. So metastatic brain lesions can be of various types, and there are different presentations we will come across, and it can be very tiny. So something like this is also a brain metastasis, which we only can pick up if we give contrast in an MR, and then only we can pick up these lesions. So this is a green arrow that is highlighted. This is also a brain metastasis. It might have a cystic change. You can see something like this. It is just only a cyst. It may have enhancement or it may not have enhancement. People are confused with this neurocysticercosis and things like that, and probably sometimes the tuberculosis if it is having a ring enhancement like this. So these are different spectrum of brain metastasis, but most of the time what we see in the brain metastasis is that you will see a lesion which is exponential amount of edema. So the moment you see an amount of exponential means it is 3 times the size of the lesion. So this is the lesion that is sitting at the gray and white matter junction, and it is throwing significant edema that is going to be brain metastasis. These are the features which can be seen in asymptomatic brain metastasis. So this is the pattern in which you see that there is a very subtle edema, or the edema might not be absent. So what is the conventional teaching is saying that METS is always occurring with edema. That is not holding true. When we are actually screening patients which is not having any symptoms, we will find out these kind of lesions which are not throwing any edema. So the lesion might be cystic, it may have enhancement, it might not have enhancement, it might be ring enhancing like this, it may be solid nodular enhancing like this, and then there are different patterns. So it might contain hemorrhage, it might be leptomeningeal, it can go into the pituitary, and it can go into the choroid plexus. So if we see in this particular patients, you will see that the folial enhancement is there. So whatever there you will see in the between the folia is the metastatic brain disease. So there are no specific parenchymal lesions, but there is only leptomeningeal disease. So there is no neuroparenchymal lesion. So if you see, usually this area should be look darker, but something which is looking bright in these sulcal spaces is going to be a metastatic disease. So this is the sulcal and leptomeningeal pattern of enhancement. Something we will call it as IV sign, in which there is the area which looks darker. If it has become bright, it is a sign that it will indicate that there is a leptomeningeal disease. And this is one of the most common pattern that even the experienced radiologist, if it is subtle, might miss it. So this is something, and it will require an expertise in that particular area. The images that we will see is the post-contrast T1 weighted images and the post-contrast flare. These are the two images which are an extremely essential component of brain screening. So something, if you don't give contrast, we are going to miss these kind of lesions. Other patterns of metastasis is that which is hemorrhagic metastasis. So if you see in the T1 which is bright, it will indicate that this is going to be hemorrhage. In this scenario, it is very difficult sometimes to tell whether it is a benign hematoma or it is an glioma which is having hemorrhage. or it is a metastasis which might be hemorrhagic. Especially if you see it is not showing significant enhancement on the post-contrast imaging, if there is a non-solid nodule around that area which is showing enhancement, then it is much more difficult. And if there is no significant uptake on the PET, so though the lesion is significantly large, but it is not showing any uptake, and then we are not clueless about it. But this lesion is progressed over the time. So if we give an interval imaging, and or either it will show enhancement on the post-contrast imaging, these are the two things that we can do to this kind of patients, and then it will tell whether it is metastasis or not. And particularly the additional imaging like perfusion and the MRS will not be effective in cases of hemorrhage. So it is a call. If we have a solid nodule apart from the area which is bright, it will tell you that probably there might be a metastatic disease. So this is the solitary lesion which is progressed over the time, and then it was resected, and then the patient is doing fine. The thing that we need to mention in the reports is that about the size of the lesion. So if it is significantly large, up to what limit they can give the SBRT, up to what size they can remove surgically, whether the lesion is solitary or it is multiple, that also has to be highlighted, because these are the constraints for surgery, for SBRT, and whether we have to give WBRT. Again, the location of the lesion, whether it is located in the cortical area or it is in the deep gray and white matter nuclei, whether the lesion is showing any edema or mass effect significantly, which we have to take care of, and what is about the composition of the lesion, whether it is having cystic areas, hemorrhagic areas, and necrosis, that when we want to follow it up, whether it will change into its composition. And subsequently, it is eloquent and non-eloquent cortex, especially if surgery is needed. So these are not without any differential diagnosis like other brain lesions. So it can mimic like glioma, it can mimic like lymphoma, and usually, so all these lesions are showing edema. So if you see the bright thing that is surrounding the lesion is going to be edema, all the lesions are throwing, but they have some difficult internal characteristics. So if you see the glioma, you will not able to differentiate the transition between the edema and to the mass. So if you see this kind of pattern, then it will indicate that you are dealing with a primary neoplasm like glial neoplasm. In this particular case, there is a very sharp transition and there is an exponential amount of edema. It will tell that you are probably dealing with metastasis. And lymphoma, which are very, very cellular tumors, they will show restricted diffusion and T2 dark, and then this is the surrounding edema. So actually on MR, even though if we pick up the lesion, we are able to differentiate before we are contemplating any biopsies, whether this is showing metastasis, or it is a primary bone neoplasm, or it is some secondary neoplasm which can be taken care of, or whether it is having some benign conditions. So you will see the another case of lymphoma here. In this case, it is very, very T2 dark, that you can see very dark. So this is how the fluid should look like. This is how the cellular tumor should look like. So it is very cellular, it is showing significant restricted diffusion, and it is showing edema. So this is a case of lymphoma. Sometimes, even though conditions like GBM, or you can call it as an anaplastic pleomorphic xanthoastrocytoma, can have variegated appearance and exponential amount of edema it can show. But there are certain diagnostic clues which will tell that because there is an scalloping, it is not destructing the bone, and the margins are relatively well defined. It looks like to be, it is a primary neoplasm. It could be a cystic nodule with cyst with a mural nodule, and then actually subsequently you will see on the surgery that the bone that was showing scalloping, actually you can see the scalloping here, and this is the tumor. So this is an PXA. So these are sometimes mimickers, and then one has to coordinate with the radiologist if there is a need. In this particular case, you will see that this is a patient of lung carcinoma, which was on follow-up, but primarily it was thought that there could be ischemic-like changes into the frontal lobe when the screening has been done, some outside center where MR is not available. When MR is done, you will see that very bright areas, which is not showing any significant enhancement on the post-contrast imaging, significant facilitated diffusion. It is a case of glioma. The thing is that once we diagnose or once we characterize these lesions, and these lesions, when they come on the follow-up, then we need to know certain things about the response assessment, and that we will follow the Raynaud's criteria that we are using it for our glioma also in the metastasis as well. So if you see, the lesion is hardly any visible on the T2-weighted scan. Without giving contrast, one cannot assess whether this particular patient is having any metastasis or not. But there was a metastasis, which was an asymptomatic one, for which the radiation has been given. And this is post-radiation, post-RT surveillance scan, where even on the T2, there is no lesion, but now the enhancement has increased. So just immediate post-RT, there could be an radiation induced changes or post-RT changes. You can see that if it is not showing necrosis, then you have to follow it up. So this patient was followed up, and after 2 years, it becomes symptomatic for the brain lesion. And then you see that there is a lot of enhancement that is coming up the site where the RT has been given, and there is an exponential amount of edema. It has been reported as there is a progression of the disease. So it is not a progression. If we do assess with the functional imaging that we are having available with us, this is the perfusion. If you see the perfusion, it is hypometabolic. The red will indicate that this is higher perfusion. The blue will indicate, and the green will indicate that it is a hypoperfused area. So this is an hypoperfused area, and it will indicate that this is an post-RT changes, and they can occur after RT. So they can occur immediately after RT or up to 10 or 15 years after RT if the patient lives so long. So this kind of pattern, if you see the central necrotic area with strong luxurious enhancement and there is an exponential amount of edema, these can be the patterns that we can see on post-RT radiation changes. What we see on MRI, the T2 weighted, if it shows nodule but which is having intermingled bright areas, it will indicate that probably we are dealing with post-RT change rather than a solid nodular enhancement. So this is how the perfusion imaging especially help in these scenarios. Apart from that, the response assessment, we will have, we can predict genetic mutations in these particular patients, whether based on the diffusion parameters, like multiple papers has been there, and it will tell that the components that are there into the EGFR mutations, they will have a ADC values that is different from the ALK mutations. So this is a semantic features that we can study on MRI. And then there are other radiomics and radiogenomics features, and my colleague Dr. Abhishek Mahajan has done his research on that regarding the potential targetable biomarkers on the brain metastasis in NSCLC patients, which can predict whether this particular patient is having EGFR mutations and not. So in conclusion, I want to highlight that MRI is very accurate in picking up brain metastasis, and it is the modality of choice, and it is non-invasively pick up the brain metastasis. It is brilliantly picking leptomeningeal and tiny nodular lesions, which were otherwise missed on the CT and PET scan, because the soft tissue resolution of both these modalities is not that great. And it will help in staging and therapy planning. And with the help of newer urgents, that is the availability of deep learning and artificial intelligence, one is able to characterize whether from what is the organ of origin of these metastases. And if we know the organ of origin, whether we can tell the certain mutations that it is harboring it. So with that, I want to conclude today's lecture. And if there are any questions, I would like to take.
Does anyone has any questions for Dr. Amit Janu? Yeah, look, you can ask your question. Press the button.
Hello. 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 Yes. Okay. So, which sequences should we focus on? Like, if there are
Sorry, I am unable to. The voice is not very clear.
You ask.
Hello. Can someone repeat who is online?
Yeah,
actually?
Amit, we are repeating the question. Just
Yeah.
Hello. Yes, sir. So which sequences should we focus on, like if there are small metastasis? So any particular sequences that we should focus on?
So I will show you the sequences that are there. So this is the particular set of sequences. The most important is the T1 post-contrast images and FSPGR. This is the most important sequence if it, because it is, you can convert it into like CT. So it is a three-dimensional picture, and it will pick up the small metastatic lesions, even around 1 or 2 millimeter size lesions. We are picking it up, and then when we are following it up, they will either increase or they will regress on the follow-up. So this is the most important sequence. So without contrast, one should not comment about whether this patient is harboring any metastasis or not. So MRI has to be done with contrast.
So we should mainly focus on T1 plus contrast.
Yeah.
That would be it. Okay.
Yeah, but other sequences are also important, because if you are picking up a lesion, then we have to characterize it, whether it is a metastasis, enhancement is coming because of the metastasis, or it is some benign entity, or some primary brain neoplasm that is giving us to picture. That has to be differentiated based on the other sequences I have mentioned.
Sir, and another one, these driver mutation lung cancers, are there any particular sites or any patterns that can be seen, or there's nothing specific?
No, so there are some features like I have already spoken about, like EGFR mutations, in which the ADC values are different from the ALK mutations and the ROS mutations. And in AI, there are some features which we are not planning, but AI is generating based on the texture and the pixels it is generating and the contrast and the margins, whatever it is taking up. So definitely it will try to segregate, and the ROC curve that is giving around these lesions is pretty good, as much as like that we are giving for the radiologists. So yes, definitely there is further scope in this, and we might able to characterize and tell the mutations, what kind of mutation the particular metastasis is harboring.
Thank you. Thank you.
Amit, I have a few questions for you. Vijay here. Amit, can you just, in Tata, it's easy for us that we ask for a MRI brain for brain meds and you do the brain meds protocol. Can you just specify, because when our residents go out, sometimes they need to specify what thickness size should be there and with Tesla MRI. So anything that if you're looking for brain meds, a specific Tesla is required, a specific millimeter size thickness needs to be taken?
So 1.5 Tesla is a good machine, and most of the centers we will now get 1.5 Tesla. Regarding the whether the specific thickness, yes, we can miss the regions if it is too thicker a slice. So FSPGR sequence, it will give a three-dimensional picture, and then because they cannot print so much images on a film, one should ask for a CD, and it will give the full details. So you can do multiplanar reconstruction, you can do coronal reconstruction, you can do sagittal, and you can do axial from that sequence, and we can actually particularly pinpoint where exactly is the metastasis sitting and what are the number of metastases that has to be treated.
Okay, thank you. Amit, one more thing I have heard. So, how, let's say that a patient had a single brain mets and he undergoes SBRT. How easy or it's difficult for you when you do response assessment scans to say that this is tumor necrosis versus this is tumor progression on subsequent MRIs?
So I will tell 90 to 95% of the time we will tell whether it is tumor progression or it is because of the post-RT change. If it is having a significant hemorrhage, or if we don't see particular features like the punctate T2 hyperintensities, and we will not see particular switches pattern of enhancement, in those areas we might have to contemplate whether actually we are having necrosis or it is a progression, that we have to take a call, and then we have to discuss with our clinical colleague in that particular scenarios. Otherwise 90 to 95% there is a probability that we are able to differentiate between post-RT change and progression of the lesion.
Okay. Do we have any questions on the non-faculty or chat? Okay. So Amit, thank you. Thanks for that nice lecture. It was very informative. I learned. Yeah. There are a few more questions which are coming. Yes, Jatin.
Good afternoon, sir. So my question is that if a patient who is suspected to have brain mets and needs to undergo a contrast MRI for the same, and say if the patient is allergic to contrast with a previous history or has CKD or other renal dysfunction, in such cases, is it still advisable to for a contrast MRI or a NCCT will be equally good as an MRI, sir?
I think that there are no contrast reaction. If the patient is allergic to CT contrast, there is a very great possibility that he is not allergic to MRI contrast. So these are two different contrast media that we are talking about. One is iodinated based and one is gadolinium based. So if something CT is allergic, we can actually very well give gadolinium as a contrast agent. If we cannot do contrast, then it is better to do plain MRI scan. That is better than NCCT, because NCCT is going to miss small lesions that are there because the resolution is not that great. So we, by definition, MRI has to be done with contrast. If contrast is due to certain regions we are not able to give, then definitely we will do a plain MRI brain. And the CT will be the last resort.
Okay, thank you, sir.
Yeah. Okay. There are no further questions, Amit. Thanks a lot. That was a great lecture. We learned a lot more things about how to differentiate between the lesions. Now,
Thank you.
yeah.